Welcome, everyone. Happy Saturday. Welcome to our sixth virtual Lupus Health Conference of 2025. My name is Elizabeth Savage. I am the co-executive director of the California Lupus Foundation, along with Tom Bakewell. We have an exciting conference planned for you today. I'm so glad you're able to join us. We will hear from Dr. Benjamin Hinton, who will discuss lupus medications, current and future, and then we will open it up to questions at the end. Dr. Hinton is a senior market access an analyst and community pharmacist. He graduated from Hampton University School of Pharmacy. Benjamin has a passion for making an impact on the community at large. Ever since his tenure at HU, he's been actively involved with improving patient access and being a health advocate, particularly in underserved communities. He aims to increase diversity in pharma with a focus on patient care, healthcare innovation, and new creating value through integrated data sets. Before we begin, I also want to thank Flex for their generous grant and GSK for being a sponsor of the Lupus Health Conferences in 2025. Please remember you can type in your questions at any time during the presentation in the Q&A section of Zoom or in the chat. Today, we're going to try something new, and we're going to open up some polling questions. So during Dr. Hinton's presentation, we hope you will participate when we ask questions at that time. Now, please, everyone, welcome Dr. Hinton.
All right. Thank you so much for having me. It's a pleasure to be here, and yeah, nice to collaborate with you, Elizabeth, and happy to be here. All right, so before we get started, I can share my screen and we can go from there. Everybody see my screen? Perfect, okay. So, wonderful, okay. All right. So is everybody looking at the agenda? Can you see the agenda? I can't see you.
Yes, we can.
Yes.
Wonderful, wonderful. Okay, cool, wonderful. All right. So today we're going to, first off, start off with introductions, with which we already did. We're going to talk about understanding lupus today. We're going to understand medication management, some insurance and patient access points, additional topics, questions, group discussion, and some resources and events, hopefully. All right. And before we get started, as far as just a HIPAA notification, any protected health information shared with the pharmacist will be protected by the pharmacist as directed. In the HIPAA privacy laws, any information shared in the open Q&A session of the presentation will be at the discretion and disclosure of the participant. Now, the disclaimers: the views and findings expressed in this document presentation and related activities are those of the authors and do not imply endorsement or reflect the views of California Lupus Foundation or the affiliates of the organization or entity or any member who has contributed to this work. Individuals have served in their individual capacity. This is not a complete list of side effects and warnings. For any unexpected effects while taking these medications, please contact your doctor or your pharmacist. The material contained within this presentation does not substitute for appropriate patient-centered medication counseling. So we put together this presentation for educational purposes only, using the time and the information that was allotted. All right. So one good thing is I got promoted during the last time we did this we did this webinar. So I'm a market access consultant. I do help out a lot with drugs launching. I understand the payer coverage and the payer dynamics. Also serving as a community pharmacist, where I'm able to put those knowledge bases together and help the community understand what the coverage looks like and overcoming those access barriers. All right, so first we're going to start off with what is SLE? What is systemic lupus erythematosus? So for starters, it is a multi-system autoimmune disease. It is heterogeneous in nature, which means it's unique. It can impact everybody a little bit differently. The prevalence is about 72.8 persons out of every 100,000 in the United States. And it definitely has a more of an impact in reproductive age females, so between 15 to 45. The prognosis is usually worse and more prevalent in those of Black, Hispanic, American Indian, and Alaskan natives and or Asian ancestry. There's a lot of other factors that play into it, from genetic, epigenetic, hormonal, infectious, and environmental factors that also contribute to the pathogenesis. So there are different types of lupus. The most common form is SLE, but it also can affect other aspects of the body. Cutaneous lupus, that's limited to the skin, can cause rashes or lesions. Drug-induced lupus is short-term and caused by specific drugs. Neonatal lupus um, that can be brought upon by way of. Ooh, hold on. Sorry, are you looking at? Let me see. One moment. Are you seeing? Let's see. So are you seeing my screen or are you seeing my notes?
We
Now
were
we
looking
don't
at your
see your screen.
notes.
Oh, thank y'all for telling me. I appreciate it. Thank you so much. All right, let me see. I can't flip this. Let me see. Now, are you seeing the slide now?
No,
I
No. Okay, let me see. I think I know what's going
we're
on.
seeing your beautiful face. No slide anymore.
Okay, let me see. Sorry about that. Let me see. Okay. So now do you see
Now we see
my.
it. Yes,
All
thank you.
right. Okay. Okay. Thank you. Slideshow. All right.
That's correct.
All right. Cool. Cool. Everybody's okay now. Everybody sees what they're supposed to. Everybody see my face now still?
Yes.
All right. That's a little bit better. All right. Thank you. Thank you. Thank you. I gotta tell me when I mess up. We're supposed to be helping each other, that's the part of this whole entire ordeal. Anyways, all right. So the different types of lupus. This gives a better understanding, a better viewership here. So there's different types of lupus, different manifestations. So to be lupus nephritis, lupus arthritis, lupus pneumonitis in your lungs, skin, heart, blood system, and as well as the brain. So it can impact in a lot of very different ways. It and that's really the nature of why it's so hard to really nail down the disease, because sometimes it can be in remission, sometimes it can have a flare, and it's really hard to really pinpoint utilizing one symptom or another, whether or not um, the whether or not the it's whether or not you can diagnose lupus, because they call it it's like almost like a mimic, like they call lupus a mimicking disease because it can also mimic a lot of conditions. All right. So I wanted to share this as an example, a lupus nephritis example of how the body develops and has a flare. So for starters, everybody has cells in their body, right? But upon the way that the body is able to rejuvenate is that when it's the cell's time to degenerate and die, it's a process called apoptosis. So usually when the system is working well, apoptosis, the cell breaks down, and then you have what's called macrophages that come in and they basically clean up on aisle 7. They clean up all the dead cells that you have and make sure that those are eliminated from the body. Now, what happens is in lupus is that sometimes the macrophages are either sleep on the job or they're just not working correctly. So it's almost like trying to catch water through your fingers. And so the macrophages, they slip up and they don't necessarily are able to detect some of the dying cells and some of the excess DNA and nucleotides, nucleic information. And so therefore, there's also two types of macrophages. So one is that the first type is the M1, and those are involved in sounding the alarm, the killing pathogens, and really doing being on their post. But when they don't regulate themselves, that's when they're able to they don't necessarily recognize the body's own cell. And then what happens is that they form an immune complex with the cells that they're actually supposed to be cleaning up. So it's almost like they don't even recognize, what they're actually binding to. And then because of that, it escalates the alarm to the other executive T and B cells that are really a part of your immune system that really sound the alarm. So in this particular example, the immune complex will bind to what is called an antigen, because the body thinks it's the autoantigen. So your body thinks that it's something that's foreign material, but it's actually itself. And so what it does is, in this case, it will bind and form an immune complex in the kidneys. And then that sounds the alarm and brings up other inflammatory agents that come in and want to attack and infiltrate, because they think they're doing their job right. They think they're trying to, take care of a foreign agent, a foreign entity. And what happens is these pro-inflammatory cytokines that are not being regulated, because these are once again the M1 macrophages, the one that are supposed to be doing, being on their post. They aren't holding themselves accountable for knowing which cells they're supposed to be taking care of. So then they kind of take over, and the M2 cells, which are really crucial for the tissue repair, wound healing, and reducing that inflammation, they get taken over. So imagine it is almost like a seesaw, and you have the M1 macrophages that forget they're doing their job. They're not held accountable, and so they just really take over the whole entire operation. And the M2, it becomes a little bit too much for them to be able to regulate. So what happens then is that there's an imbalanced pro-fibrotic polarization, and what that means is like there's just an imbalance in the maintenance of the homeostasis, and then the defective phagocytes continue to the defective phagocytes kind of prolong the issue, and then that's when you have the kidney fibrosis that end up happening, because the tissue starts to die as a result of the cells attacking themselves. And the thing is, this can happen in pretty much any portion of the body. So in terms of the relevant signs and symptoms of SLE, when it happens in other parts of the body, it would show up as being like prolonged or extreme fatigue. Your body's continuously fighting itself. You might have a fever over 100 degrees Fahrenheit for several days, swollen knees or joints. There's weight changes, butterfly rashes, which is also called the malar rash. You may also have chest or abdominal pain. If the lupus is affecting your heart, you might have difficulty breathing or shortness of breath, unexplained muscle pain or weakness, alopecia, hair loss. Your skin might be a little more sensitive to sunlight. You might have kidney issues because of the place that it's actually the inflammation is actually happening. You might have mouth sores, which are sores in the skin that like do not heal over time. And then also some things that is also kind of hard to really kind of hone down is it might impact your brain as well. So that's what happens when you have brain fog or memory issues or focusing issues. And then there's also eye redness, irritation, inflammation, and scarring in the eyes. So it really depends on where the immune complexes ended up floating around in the body. It also can lead to issues in the blood and the blood vessels, such as like blood clots, anemia, and Raynaud's phenomenon, where a lot of times when you're in cold weather, your fingers turn blue abnormally because they're not able to regulate the blood flow there. So lupus is as you can see, lupus is one of the hardest diseases to diagnose because of the fact that it mimics so many other conditions. When you walk into a doctor's office with joint pain, fatigue, and a rash, there are literally like dozens of possibilities. So that's why it takes an average of like 6 years and 3+ doctors to get a lupus diagnosis at this point in time. But as we'll discuss later, there are new developments that are hopefully speeding up that process, and we'll be able to hone down the disease state in a lot easier fashion. Last point I wanted to make is doctors use a point system. So they use an ACR and a EULAR classification criteria. So you need a ANA to start. You need a autoantibody test in order to kind of start. And then once it's a positive test, then they look down at the different 7 categories, whether it's your skin, your joints, kidneys, blood, autoantibodies, and then they start to get points. And then after 10, you meet the criteria for lupus. And in people with SLE without kidney disease, we strongly recommend screening for protein in the blood every 6 to 12 months, especially if you're experiencing any extra external renal flares, because we don't want that to end up trickling into the kidneys. So this is what I mentioned earlier. There's so many different places where the body can be impacted. I mentioned the mouth, nose, ulcers, heart involvement. And then to your right, on the right side of the screen, the first entry to even being considered for lupus is having a positive ANA. So once the positive ANA is documented and seen by the lab physician, that's when you start going into the other different factors to be considered. Now, the one thing about that is about 10 to 15 people, 10% of healthy, 10 to 15% of healthy people still test positive. So that's why, even if you have a positive level, and that ratio, when you get the lab test back, it would be at least one to, like, the ratio would say 1 to 160 or 1 to 320. Once you get to that 1 to 320 range, that's almost like an indicator that you're going in the right direction as far as determining what if it potentially could be lupus. But it for sure will let you know if you have an autoantibody like autoantibody disease. All right. Let's see. Okay. So how is lupus treated? So um there's many ways that lupus can be treated depending on where it shows up in the body. And the guidelines were actually just published last week, so that is really great news for everybody here and for everybody involved and for everybody that is looking to support lupus or looking to to seek signs. They actually were just published last week, and this was the first guidelines for it for lupus since 1999 by the American College of Rheumatology. So since then, treatment regimens were incorporating, mycophenolate, mofetil, mycophenolic acid, or lower dose cyclophosphamide, which have been proven to be effective compared to the older, higher dose cyclophosphamide regimens. But in these guidelines, they really put a harp on shared decision making. So what that means is the patient having a shared decision making with the physician and coming to a treatment decision by way of working together in conjunction. Because a lot of times, the patient has to be empowered in order to make the best decision. And a lot of times when you're going through, it may seem hard, or you want to think that the doctor always knows best, but it's a hard disease to kind of pin down. So they need your help. They need, we need all the help we can get in order to understand and be able to completely nail down this disease. And I think what also makes it hard is that there's two types of SLE symptoms. So sometimes the type 1 is more inflammation. The type 2 is more like fatigue, generalized pain, and brain fog that impact the quality of life. So in type 2, symptoms are incompletely understood. They really don't know exactly how, or the mechanisms of those type of symptoms per se just yet. Similarly, like depression, anxiety, things of that nature. So these are medications that we use mainly when I talk about treatments are going to be for the inflammation and pain. So as far as the drug class, we have immunosuppressants, autoinflammatories such as NSAIDs, antimalarials, and anticoagulants, and antihypertensives. So the purpose of the immunosuppressants is to kind of keep the immune system kind of tapered down and to calm down a little bit. So it prevents it from attacking the body, with the goal of tapering therapy after 3 to 5 years, with the goal of really discontinuing those medications, especially if they are immunosuppressant. So examples that you may have heard of is methotrexate, leflunomide, thalidomide, cyclophosphamide, cyclosporin, tacrolimus, azathioprine, belimumab, rituximab, and the latest one is Gazyva. That was approved literally last week. Week before last. So that's great news. It's an anti-CD20 agent. It's approved by the Genentech. but it's something that we were looking forward to for some years now. They met all of their primary endpoints, all of their secondary endpoints, in reducing flares and sustained overall response. So I'll talk about that a little bit later. But for the most part, the areas that we want to prioritize are the ones that are at the greatest risk for irreversible damage. So that's going to be reducing the inflammatory responses so that the organs are saved. So as far as the NSAIDs and anti-inflammatories, once again, they assist in reducing inflammation and pain. That looks like corticosteroids. And part of the new guidelines also touches on how the approach shifts from maybe waiting and seeing and slowly tapering up to no, they want to knock it out. They want to knock out the immune response as soon as possible. So they're going to give you a high dose. Well, they're going to give patients, if you're having a flare, they're going to give you a high dose of methylprednisolone for what's called a pulse, which is a high dose for 1 to 3 days. And then after that, they want to give you a prednisone and taper down to about 5 milligrams per day, with a goal to taper less than 5 milligrams a day until 0 within 6 months. And the mainstay of treatment is really Plaquenil. It's the next one, hydroxychloroquine. It is an anti-malarial drug historically, but it acts as an immunosuppressant to keep the immune system from attacking the body also. And it works in several different ways. And that's why it's so unique, and it helps because a lot of times we're trying to find something that will keep the cells at bay, keep the inflammation system at bay. And because it works in a few different ways, it's great at doing that. Now, it is contraindicated if patients have an allergy to it, or if they have what's called a glucose 6-phosphate dehydroxygenase deficiency. And what that is, it's a genetic disorder that protects the red blood cells from oxidative stress. So if you have that deficiency, then you can't take Plaquenil, because both the deficiency and the drug can cause the hemolytic anemia, and that's a condition where the red blood cells are destroyed. So we want to make sure that that's not the case. You talk to your doctor about those and get tested for that before. Next, we want to move on to anticoagulants, and they help the body in reducing and preventing blood clots, and the coagulation of the red blood cells, right? Because when you have the immune complex, that can also cause blood clots because of all the different inflammation that is going on in the body and the different cells that are coming to what they believe is the rescue. Lastly, antihypertensives such as ACE and ARBs. There's not necessarily a first line agent for either one, but they help with, especially in lupus nephritis, they help to lower the blood pressure. That way we don't have as much effect and impact and pressure on the kidneys. All right. I touched on hydroxychloroquine a little bit. So now we'll talk about some of the contraindications and warnings briefly. So Stevens-Johnson syndrome is like a really quick rash that happens as a result. So that's something to look out for. They have toxic epidermal necrolysis, and that's when the skin pretty much peels back and it really becomes inflamed, and it really just dies all of a suddenly. So it can be really bad. Essentially, I probably should have put pictures up here, but essentially the skin just starts to die in specific areas. So that's something to look out for. They have cardiac skin, blood sugar changes. It can cause renal injury, neuropathy, psychiatric suicidal behavior. It can cause impact to the immune system, liver injury, and also it can cause vision changes. So that's one thing that I wanted to touch on the most as well, is because when you're taking this medication, you want to really get your vision checked every 6 months, and at least like a year. Every year you need to get your vision checked, just to make sure that you're not having any changes. I actually just got my eyes checked this past year, so it's been a while, and my vision has changed. So like sometimes it naturally happens, but you want to be able to have a baseline so that you can be able to tell, okay, this is how my vision was now, and then be able to track it over time. All right. And then as far as the NSAIDs, they are contraindicated in pregnancy, because they can cause birth defects there. As far as aspirin, you really don't want to take that with if you're pregnant as well. It could also cause gastric ulcers with prolonged use. As far as immunosuppressant and methotrexate can cause nausea, vomiting, diarrhea, dizziness, mouth ulcers, alopecia, photosensitivity, rash, decreased levels of immune cells, joint or muscle pain are common also. You definitely do not want to take this while you're pregnant. It can cause hepatotoxicity, myelosuppression, acute renal failure, GI toxicity, dermatologic reactions, malignant lymphomas, potential fatal opportunistic infections, because once again, you're lowering the immune system just a tad. And so because of that, you can become more susceptible to other infections as well. And it's contraindicated in pregnancy if you're breastfeeding. Definitely, if you're addicted to alcohol, that's something that we definitely don't want you to be taking methotrexate on. Chronic liver disease, any blood diseases, or an immunodeficiency syndrome. As far as live vaccines, you need to ask your doctor or pharmacist. We really do want to avoid those, honestly, if you have lupus, because of the fact that your body would not be able to regulate it as much as you would a dead vaccine. And once again, as I'm going through the side effects, this doesn't happen to everyone. It's just a percentage that they've documented throughout the clinical trials that they've had over time. But the thing is, it's important to note, because then you can be able to tell which, when you feel these symptoms coming on and when you feel the side effects coming on, and also be able to tell and identify the mechanism for how it came about, if it's due to the disease or if it's due to you taking the medication. So you want to be able to track those as well. So I'll touch on that a little bit later. They also have a couple of immunosuppressants as far as leflunomide and thalidomide. For the side effects, some things can potentially impact you are alopecia, weight loss, liver enzyme elevations, diarrhea, headache, respiratory infection, nausea, and it's contraindicated in bone marrow suppression. Now, the thalidomide, it can cause fetal harm, so that is a contraindication as well. Black box warning there, and it can cause severe skin reactions and nerve damage. Some of the side effects that have been noted is hypotension, drowsiness, decreased platelets, and bradycardia and white blood cell count decrease. All right. So next, we have the azathioprine, and some of the most common side effects are nausea and vomiting. Usually mild. You could experience swollen joint fatigue, a little bit loss of appetite and muscle pain. Some of the rare but serious side effects include pancreatitis, increased risk of cancer, decreased white blood cell count production, anemia, and some of the others there. Some of the contraindications here is the chronic immunosuppression with azathioprine increases the risk of cancer. So particularly cancer of the skin, lymph system. So for these, you just want to, once again, you want to talk to your doctor and assess all of the different options before and the risk involved. And depending on, and one thing I will say that changed in the guidelines is that depending on where the flare is happening, that is where the different course of treatment will be derived from. Benlysta, I'm going to cover in a future slide, and cyclophosphamide, that is also one of the main drugs of care as well. But it can cause alopecia, skin pigmentation, rash, different changes of the finger toenails. Also cause some heart effects when it comes to the heart, skin, the liver, and some kidneys as well, and some of the lungs as well. And as far as in male patients, it can cause a low sperm count, especially during orgasm. It could also, for toxicities and warnings, it can cause skin cancer, renal, productive immune system issues, liver and endocrine, metabolic, cardiotoxicity, and lung issues as well. So once again, it's just something to talk to your doctor about. I won't read through all of these in the essence of time, but there are some different drugs here for mycophenolate, rituximab. That's the CD20 that is one of the mainstays of refractory lupus. They also have tacrolimus, cyclophosphamide, and methotrexate as well. And you see the contraindications and warnings here. And I can definitely send this slide or these slides out afterwards. Just want, for the essence of time, I want to keep moving forward. All right. Can we do a quick poll? Real quick, can we do a quick poll? How does everybody feel? Can we do a quick poll? Take a break in the action.
Yes, let's do a poll question.
All right, let's do it.
So the first question is, how many of you, if for answering the poll, if you could put it in the chat so we could see that, how many of you were diagnosed within the last 5 years with lupus? And how many have been living with lupus for 10+ years? So let us know if you've for last 5 years or 10+ years.
Or if you know somebody that has been diagnosed in the past 5 years, or have been dealing it with the past 10 years. I know my cousin she was diagnosed with lupus about 30 years ago. So she's been dealing with it for a while now. And then my god sister, she's got diagnosed just recently. So the doctor thought it was allergies for years. And she finally, after many lab tests and many years of trying to figure it out, she was finally diagnosed with lupus. So that was a sign of relief, but also another chapter in her journey where she had to realize, okay, now this is what it's going to be looking like for me going forward. So absolutely. Elizabeth, do we have anybody yet? Just yet?
Nobody's participated yet. Let's
No,
do
yet.
another question then.
All right.
What symptoms led you to first seek medical care? Was it the butterfly rash, joint pain, or was it something else?
We get something yet? Did we get anything come in? No, not yet.
I don't see
Oh, they're
anything.
being shy. Come on, chat. Come on, chat. I guess they're being a little bit shy today. But okay.
Wait, okay, so Karen, someone just put in that the chat is disabled, so they're not able to answer. So Maggie, are you able to get the chat? Maggie, are you on? Okay. Well,
Yes, I am here. I'm just actually typing something. Can you see it? Can you see what I?
no. So
No.
the chat's disabled?
I don't see here that it says disable.
Oh, well,
Let me
maybe
see.
just put it in the Q&A. Ask questions and we can pivot. So instead of putting it in the chat, oh, I can see it in the chat. Yeah, I can see the communication from the communication director. I can see the chat. Now, can the panelists, can you see the chat?
Okay, now I can see it.
So it is working actually.
Karen, can you see it? Okay, so
She said
got
30+ years
we got
and
one
hip
response.
pain.
30+ years. If you want to use the Q&A, then that might, oh yeah, okay, so now you can see in the Q&A, they can see the Q&A.
perfect. We'll do the Q&A. Perfect.
Okay.
Thank you, Karen. Thank you for your participation.
Yeah,
Appreciate
thank you. And so response, we have 30+ years, and then hip pain. Hip pain was what brought you to see the doctor, and then that's when you were diagnosed with lupus? Wow.
All right. Well, thank you for sharing.
Yeah,
I appreciate
thank
that. Wow. Okay. So we're gonna keep going. In the interest of time, I appreciate the participation. So
Oh yeah, there's another answer here
okay.
from Karen about the hip pain. So it took about 5 years to be diagnosed.
So you knew before they did.
Yeah.
Wow. So Karen, how did you find out? Was it you were looking up different symptoms? You started to do more research about it. And what was your conversation like whenever you had the conversation with the doctors? So you can if you'd like, you can put that in the chat and I'll keep going that way, because that actually is a great segue into my next piece here. So the lupus nephritis treatment tree. I'm going to touch on this one first before I go to the SLE. But so essentially, there's so many different ways to try to diagnose lupus, and for the lupus nephritis, once again, this just came out this year. So they want to have like the names, the mainstay of treatment is going to be hydroxychloroquine, especially if you have lupus nephritis. They're going to also add in a renin angiotensin aldosterone system inhibitor, such as like, ACE inhibitor or ARB. They're also going to put you on a steroid. They're going to give you once again, a high dose of the corticosteroid based off of your weight. And then they're also going to give you a mycophenolic acid and one of the treatments below. So based on if it's outside of the renal, the kidneys, they're going to give you belimumab, otherwise known as Benlysta. If you have no specific risk factors present, they're going to touch on incorporate patient preferences. Now, this is a really big key, especially going into, moving forward. It's more about how the patient's lifestyle is. How does it work within your life? How does it work within what you're aiming for treatment? Everybody's end goal is not the same. So it's seeking to proactively incorporate the patient preferences in the decision-making process. So based off of that, if you say, for instance, you don't like injections, then, the calcium urine inhibitor might be one that's, more aligned with what you would like to pursue. And the goal is to reduce the protein in the kidneys under get it down to like a normal level within 6 to 12 months. So if it works, the treatment regimen works, then with a goal of less than 5 milligrams per day in 6 months and it's achieved, then you're going to continue this same therapy for 3 to 5 years. Now, if you still are trying to find out that if it still has that status after 12 months, then you're going to individualize therapy. And if the rate and you still have protein in the urine, you're going to assess the adherence. And then if not, you're going to have to switch to a different therapy. So one thing also, this is given that the patient is always taking the medication as prescribed and on time. It's hard enough to get up, make your bed in the morning, get a system in place. And so it's even harder sometimes to take medications, especially when you're taking multiple. So if you're taking triple therapy, sometimes it's a lot to remember, but adherence is key in order to get this disease into remission. And I won't go into everything because you want to have those conversations with your doctor for sure, because it is an individualized therapy. So this is, but depending on this new decision tree, that's the type of conversations you will have with your doctor. So now whenever you go to the doctor, you can say, hey, I know, and it can also spark another level of conversation with them, like, hey, the guidelines just came out. Can you take a look at this? Can we take a look at it together? So that's encouraging both the patient and the provider to work together. Okay. And this is a broader treatment map. Now, this is different than the treatment guidelines before. Before I mentioned they would have a certain amount of drugs for, say, for instance, mild, moderate, and severe lupus, systemic lupus. But now they're addressing specific organ systems. And based off the specific organ systems, they made recommendations to particular drugs that address the severity of the disease based off of, once again, the organs that are being impacted. So this is completely different than what they were using before. Before, it's more like on a broad level, but this is more tailored and more personalized. So what this also encouraged patients to do is write down in their journals and say, hey, this is what's going on. This is how long I've had it. This is, I have an intolerance to this medication, so let's try something else. So especially when the only key things here that are the same across the board is the fact that they want you to take Plaquenil unless contraindicated. They're going to give you a high dose of steroids in order to kind of knock out that inflammation right out. And then as they identify the different organ system, they're going to escalate the therapy from there. So now quickly, we're going to go into the recent FDA approved agents. Kind of recent, not so recent. Benlysta. So this is an anti-B lymphocyte stimulator antibody. It's for treatment of patients 5 years and older with active autoantibody positive systemic lupus and patients 5 years older with lupus nephritis receiving standard therapy. So what that means is that you're going to take this in combination to what therapy you've already have been taking. This is right now, it's currently IV. It's also approved sub-Q as well. And it is based off of your dose. So if you weigh, for instance, if you weigh for an SLE, if the subcutaneous formulation is available, if you weigh between 15 kilograms and less than 40, you're going to take 200 milligrams every 2 weeks. In adults, you're just going to take 200 milligrams once a week. In lupus nephritis, the dosing is only available for adults currently. And then that would be administered as a 200 milligram injection weekly into the thigh or the abdomen. Once again, it's sub-Q. And then if you are on the medication for lupus nephritis, you're gonna have 2 injections for the first doses, then once a week after. Store both of these in the refrigerator and do not shake or freeze the solution. Now, the one key part here is that some of the medications may not take into effect the next day. So this one, the efficacy is at 6 months. Like you see it, the efficacy at 6 months, and up to 86% of patients reduced or discontinued steroid use. So that's what we're looking for, right? So the mainstay of treatment is to taper down the corticosteroid uses as much as possible to prevent the other side effects from that, which is, increased blood sugar, increased blood pressure, and the other side effects that come with that. Let's see. The patients had a reduced the efficacy of the trial. The patients had reduced disease activity, the amount of flares, and a decrease in disease severity, specifically in African American and Hispanic patients. Over 60% had improvement in joints, skin, and kidneys versus the standard of treatment alone. So if the patient were just taking mycophenolate, they were only taking steroids, this in addition to provided an improvement in their symptoms. It is contraindicated if you have an allergic reaction to Benlysta, and is also if you're pregnant, avoid therapy for at least during pregnancy and at least 4 months after. All right. Some of the warnings that I want to highlight here is, once again, hypersensitivity, allergic reactions, increased risk of infection, vaccines. So I know there was a question about vaccines. So you should always, I won't say always, that's a strong statement, but you should shoot for non-live vaccines. So like your flu shot, COVID shot, vaccines that are inactive. When you're looking to avoid vaccines, you're more so looking to avoid like your live vaccines. And those are the ones that they can stimulate your immune system, but it's because you're already suppressing your immune system. You don't want to create more problems than what you need to. So live vaccines such as yellow fever, MMR, smallpox, those aren't recommended within 30 days of or during your Benlysta therapy. It can increase your risk of cancer. It can increase the risk of psychiatric events such as like depression, suicidal ideation and behavior, and other psychiatric events have been reported. Once again, this doesn't happen to everybody, but I just want to highlight once again that there's something that they have identified as being prevalent. And one of the key points here is if you can't afford it, I would definitely look into therapy. It's helpful to be able to track how you're feeling, be able to process those emotions, and it's very good, especially when you're because stress is a huge driving factor in a lot of autoimmune diseases. So being able to identify what your feelings are, work through them, process them in a whole myriad, especially in today's world, there's a lot of things that can stimulate us in different ways, and so we want to be able to manage them to the best way possible, and then also be able to share our thoughts and feelings with our loved ones that can help support us the best way possible. It does have an increased risk of PML, which is progressive multifocal leukoencephalopathy. And essentially what that happens is you have different places within the brain that can progress, and the risk is increased with immunosuppressant therapy because the body's not able to actually regulate it. So that is something that you should consider the neurologist consultation and discontinue treatment. If that happens, it can result in death and severe disability. you would know, like if you notice any memory loss, trouble thinking, dizziness, loss of balance, difficulty talking, that's definitely something that you want to check out with the physician. I touched on other warnings, just some of the side effects here: nausea, diarrhea, some other serious side effects down below. Once again, I don't want to read all the slides for the essence of time, but these are definitely something that are common, whether it's fever, infectious disease, can cause a little bit of insomnia, leg or arm pain. I definitely have some hypersensitivity reactions per se, especially since it is an injection. And they could also have some serious infusion reactions at the infusion site, as well as some behavioral side effects as well. So next, I'm going to talk about lupus. The generic name is voclosporin. Oops. It is a calcineurin inhibitor used for active lupus nephritis. It's not recommended for patients if you have EGFR less than 45 milliliters over like that's like the rate, the glomerular filtration rate, the glomerular filtration rate. That's a mouthful. But unless the benefits outweighs the risk, or in patients with a blood pressure of 165 over 105. It in the clinical trials, it provided a faster time to complete renal response when you have to starting therapy compared to the standard of care. Now, calcinurin's role in your body is to activate T cells, which is a type of immune cells. So lupus binds to that calcinurin and inhibits it, which prevents the T cells in your body from triggering an autoimmune response, resulting in decreased inflammation in your kidneys. So that's why this one works so well. All right. Let's see. And some of the warnings to be mindful of: it can cause an increased risk of infection, bacterial, fungal, opportunistic. It's important to once again avoid live vaccines. It can cause a fetal risk, and hyperkalemia, which is elevated potassium levels in your blood. That also can impact your heart rate as well. So, once again, like when you're getting diagnosed for lupus, they're gonna have a whole panel, a whole suite of different tests. But these are something that you want to bring up to your doctor to have a conversation about. And it's contraindicated in strong CYP3A4 inhibitors, such as ketoconazole, itraconazole, clarithromycin, because it prevents it from being broken down. The safety and efficacy of cyclophosphamide with lupus has not been studied, so avoid that if you're taking this drug. And once again, you're going to have per the guidelines, you're going to have a really in-depth conversation with your provider about which drugs work best for you. For some of the common side effects, hypertension is common, once again, because it's working at the kidneys. And kidneys is responsible for so much. It's responsible for filtering out the waste. It's also responsible for managing your hypertension, like your blood, your blood vessels. The renin that is produced in the kidneys pretty much affects whether or not your blood pressure is going up or whether it's going down. And that is why the medication works at that site, but it's also why it can cause some hypertension there. So patients should monitor their blood pressure regularly and speak to the doctors if they notice their blood pressure is getting out of control. Let's see. And if you're on any other calcium channel blockers or blood pressure medicines, they could interact with the drug, and so you have to contact your doctor to come up with a regimen that is more aligned with your needs. All right, and then you see some of the other side effects there: mouth ulcers, dyspepsia, fatigue, tremors, decreased appetite also. So next, we're going to go to Safnello. Let's see, we're doing on time. We're doing pretty good. Okay. Safnello, that is an interferon 1 receptor antagonist. Now, interferons, they're the mechanisms that go from cell to cell, knocking, saying, hey, and ringing the alarm. So when you get, say, for instance, when you get a vaccine, and a lot of people say, oh, I feel like I got the flu vaccine and I got the flu. No, you really didn't get the flu. You received some flu-like symptoms as a result, and these are the ones to blame. These are the individuals to blame. So they're interferons. They go from cell to cell knocking, and that's what causes the fever, the chills, and a little bit of soreness as well. FDA is FDA approved for adults with moderate to severe SLE who are receiving the standard therapy. It has been evaluated with patients who are with active lupus or have severe active central nervous system lupus. See, it's not recommended in those cases. It's still being defined. They're still working on the benefit, but this just haven't been approved just yet. The dosing here would be an IV infusion over 30 minutes every 4 weeks, so once a month. Here, some of the side effects: hypersensitivity reactions, including anaphylaxis and angioedema, increased risk of infections, cough, tuberculosis, and so those type of infections could be prominent with this medication. Once again, you should be up to date with all your immunizations before, so that you don't necessarily run into this. And a lot of vaccine, once again, should not be taken with this medication. All right. So lastly, in terms of the medications, we want to talk about Gazyva. This was just approved for active lupus nephritis. Woo! So by show of hands, or maybe in the chat, talk to me. See, have you heard about this medication? Did you hear about the approval? I want to take a moment to involve the chat a little bit.
Yeah, go in the Q&A.
The Q&A, yeah, go in the Q&A chat. Q&A chat. Oh, okay. We have some questions here. Let's see. Does marijuana help heal lupus? That's a great question. And the short answer is no. Like smoking can also cause a little bit of inflammation as well. I know sometimes, like, it can calm nerves at sometimes, but smoking can also have the opposite effect, where it can cause inflammation, whether it's in the lungs, and whether it's other parts of the body also. So it can't heal. There is no official cure for lupus, so I can't say that it heals lupus. I know it sometimes can put people at ease to some degree, but even then, I think we also have to touch on whether or not we're using it to cope with actual stresses in life. That's something that sometimes people use it to cope, but sometimes if we get to the root of the issue, it can also help us knock that out as well, and actually address those stressors head on. That's a great question. Okay, so anybody in the chat, has anybody heard of Gavzaya? Think so. Doesn't sound
Karen,
like
you
it.
have a healthcare background. Have you heard of it?
Who, me?
No, Karen Vickers in
Okay. Oh,
the,
yeah.
yeah.
I got it. Yeah, Karen.
Oh, first time. Okay.
All right. All right. Woo. Okay. Well, it was just approved less than a couple weeks ago. So you're off the hook there. So this was a long time coming. Even last year and the year before last, when we did this webinar, we were looking forward to it. I had it as one of my had it circled as one of the treatments that I was looking forward to. So it's recently approved for active lupus nephritis, and then it recently announced positive data for SLE. So that is a huge deal. It's going to be the first antibody or anti-CD20 therapy for SLE to directly target the B cells, and that is a key driver of inflammation and disease activity. Now it will be an infusion. The first infusion is going to take about 4 to 6 hours. They're going to give you some pre-meds to prevent the reactions. You still might feel a little bit feverish, itchy, or nausea, but this typically gets better with every infusion. And before you start the medicine, they're going to want you to get your vaccines now, especially for flu, pneumonia, and COVID. They may not work as well if you're on the medication, because once again, it is immunosuppressant type of drug. All right. And then really, one key here is like to avoid people that are sick. And you don't want to be around a lot of people who are coughing, because that's going to be an issue, right? And one thing to keep in mind too is that your B cells, it's a B cell depleting type of drug. However, your B cells will eventually come back, but until then, you're going to be more vulnerable to infections. Excuse me, when you're on this medication. So I'm definitely excited about this, as well as the next approval as well. See. Some of the black box warning we touched on, progressive multifocal leukoencephalopathy, and then hepatitis B reaction as well. Those are two things to keep in mind. Those are the black box warnings there. But outside of that, some of the side effects is, if you contact your ND, if you have a fever over 100, if you have a new rash, especially blistering or spreading, if you have a persistent cough, shortness of breath, pain for urination, easy bruising, nosebleeds, that's something that we can, we'd like you to talk to the doctor about, to really see what is going on, if it's about if the drug itself is causing it, or if there's something else that needs to be taken into account and investigated. Once again, some of the severe warnings are, throat swelling, unable to breathe, severe chest pain, severe hypotension. Signs of PML are new confusion, vision loss, weakness on one side, difficulty speaking, some severe infections, severe bleeding, once again, because you're lowering your immune response a little bit. And also, if you have a potentially have a cardiac emergency, that would look like chest pain, severe palpitations, and or fainting. So, but either way, you're going to want to look to make sure that you want to get a differential diagnosis. You want to get a differential understanding of whether or not it's the lupus happening or if it's the drug itself. So next, I want to go into insurance and access challenges. So I'm not sure how familiar everybody is on the call with a prior authorization or a step therapy, and maybe that's a great question. So put it in the chat and the answers and the questions and the answers if you've ever heard of a prior authorization before, or if you've ever experienced you already beat me to it, Karen. Oh, you just beat me. Look at you. Look, I knew you was onto something, Karen. Wonderful. So that is a great question. Are the insurance companies on board since it is infusion? So the thing that happens with a lot of drugs, especially once they're coming on board and recently approved, usually they go through what's called a new to market block. So the first 6 months, the insurance won't cover it. They're still getting their policies in order. They're still trying to figure out, what the actual J code, how to bill it correctly. And a lot of times insurance companies won't necessarily cover the drug outright. However, over time, there's something called a medical exception that you can use in the meantime. There's also copay cards. There's also trial cards as well. And a lot of times, especially during launch, companies on their manufacturer website, so you can look at either one of these: Safnella, Benlysta, Gazyva, Lupus, like they will have copay cards on your website. And depending on the insurance coverage level that you have, you can qualify for these different programs. So if the insurance denies it, you might qualify for a trial card. If your insurance does cover it, and when it does cover it, then you might have a particular copay associated with it. But the manufacturer will reduce your pay out of pocket in order for you to be able to access this. And they're usually will cover it until the resources run out. One thing I do want to harp on here, because a lot of patients I hear, they haven't heard of what's called a prior authorization. So a prior authorization is basically a review period where your insurance is reviewing the drug that has been billed to them, and they can decide either to approve it or deny it. So when the prescription is initially sent to the specialty pharmacy, they will receive the rejection because they're going to bill it to the insurance. And then the insurance will say, hey, we need to take a look at this. This is an expensive drug. We need to know a little bit more information about it. So the specialty pharmacy will reach out to your doctor's office with say, hey, we need this form filled out, the prior authorization form. Can you do that? The doctor will then fill the form out, let them know your diagnosis code, let them know why you're taking this medication, all the justifications, especially if you've already been taking other medications such as prednisone, methotrexate. You've already been taking all the other medications, and you're currently on the medications. Then they'll send it to the insurance company, say, hey, check. Karen meets all the boxes. So now we're good to go. So then they'll either approve it or deny it. Now with new agents, a lot of times they may deny it for a while, but at the same time, it depends on your insurance. So in a lot of times, especially with the copay cards and the trial cards, as long as the prescription has gone through and at least tried the insurance, a lot of times they do cover it, depending on what type of insurance that you have. And then even when you're signing up on the website, a lot of times they will align you with the case manager. So all you have to do is ignite it. All you have to do is initiate it. And a lot of times they'll take the next step and make sure that, whether it's a field reimbursement manager or a case manager, they'll make sure that they are checking your benefits and helping you navigate to the appropriate funding. They also have foundations as well. If you don't qualify for the funding, they have a foundation that you can pivot to, and they'll also help to together to get funding to you and to help you cover the medication. Let's see. I touched on medical exceptions, step therapy. That is a big one because a lot of times that is one of the differentiating factors between you getting the medication and not getting it. The insurance company just wants to see that you've tried and failed a couple agents before they pay out of pocket. The deductible, that's an amount that you have to pay prior to the insurance kicking in and paying a little bit more. And then out of pocket costs, depending on what the medication is, you may pay $10, you may pay nothing at all. So once again, the specialty pharmacy will likely ship this medication to you. You're not going to be able to go to CVS, just regular CVS or Walgreens to pick up this medication because it is expensive. Most likely they will the doctor may send it to that pharmacy, but then they'll ship it to their specialty pharmacy that is preferred by your insurance. And based off of that, you'll either receive it at the infusion center or you'll receive it at the doctor's office. But once again, that's based off the insurance's preferred site of care. Sometimes, to your point, Karen, you might go to an infusion center or you might have to go into outpatient. It just depends on what it is. All right, let's see. All right, some questions that I want to recommend asking your doctor is, when you're having discussions about which therapy is right for you, you should be asking, why are you recommending this medication over others? Why, like, what are the risks and benefits of this particular medication over others? How we know if this medication is working? Like, what are some signs that you can look out for, that I can look out for? What if I can't afford it? And then what happens if I do nothing? I know these are all valid questions, but it also puts the power into your hand as the patient, because at the end of the day, we may not have been born with the disease, but it's up to us whether to handle it. It's up to us how to confront it. It's up to us how to manage it. And that might look like setting boundaries. That might look like exercising more. That might look like eating healthier. I'll talk about it a little bit later on down the line. But at the end of the day, if you have a doctor that isn't listening to you and isn't allowing you to express yourself, you don't feel comfortable expressing how you're feeling and how you've been feeling over the course of days, weeks, years, either leading up to the medication or even after, then it might be time to switch to another doctor that you feel comfortable with. And if you have to have somebody that is there to support you, that might be a good idea to pursue. And if maybe you're not the patient, maybe you're somebody that is supporting somebody that has lupus. Put yourself in their shoes. I know that you're here, so I'm sure that that's something that you really care about already. So just want to encourage you today to continue to walk down that path and continue to be there for those people in your life. So somebody reached out and shared some questions about what are some non-medicinal ways to manage lupus. So first and foremost, sun protection and UV avoidance is one of the most important things because it can cause flare-ups with the skin. You might see the butterfly rash. And the thing about inflammation is once it starts, one place in the body, sometimes it spreads to others. So that's something that is definitely important. Putting sunscreen on, making sure that you have long sleeves. Especially in California, like the sun is very bright, it's very direct. So that's something that I definitely want to emphasize. Diet and nutrition is another. It depends on how you eat, what you put in it is sometimes how you put out. Sometimes with lupus, that's a little bit difficult. It's nuanced there, but you don't want to make the situation worse by just eating bad and just eating terrible. So obviously you have a cheat day every once in a while. You want to celebrate, go for it. But overall, diet and nutrition is very important. Exercise and physical activity. This is one that is nuanced because sometimes your joints hurt. Sometimes you don't feel like going out and walking. So my encouragement to you is to do the best that you can. If you can walk for a bit, if you can, take a lap around the neighborhood, breathe in the fresh air and utilize those different ways to lower your stress levels. Sometimes that's all we need. Sometimes we just need to get outside and breathe and take a breath of fresh air and just take a break. So that is completely valid and that's completely okay. Critical thing is stress management. So exercise, diet, and nutrition, that helps with stress management, but that is critical. When you see yourself getting worked up, when you feel like you're in high pressure situations or feel like you're in, maybe you have relationships that may not be as beneficial to you, or situations at work. If you're seeing yourself get hyped up or feel like in a stressful environment, know how to manage that. That's what I mentioned, going to therapy as well, and really so that you can kind of sit with yourself and really understand what is actually causing these issues. Sleep hygiene is very important. Now, when you sleep, your body is able to recover, and especially with lupus, you seems sometimes you feel like you're always fighting. So being able to sleep and let your body rest and recover is something that's very important. Um, Especially because it's fatigue is something that happens a lot, whether it's mental fatigue or physical fatigue. So being able to make sure you have adequate, at least 8 hours of sleep, or even more, 8 to 10 hours of sleep if you can. That's very important. Smoke cessation, that's non-negotiable. I know that was a question in the chat. Smoke cessation, especially nicotine and marijuana can be placed in that as well. It does impact the overall, it does impact overall, some it can trigger, like, it does impact your overall health. And so it can also trigger some lupus flare-ups, depending on how it impacts you. So everybody's a little bit different, but smoke cessation is something that you definitely is causes flare-ups for sure. Avoid the known triggers. So if the pan is hot and it's hot, do not touch it. You got to know what triggers you. And I have a quote from John Maxwell. He said, "You have to know yourself to grow yourself, and then you have to grow yourself to know yourself even more." So my if it's journaling, if it's drawing, find some things that calm you down. Do the complete opposite. There's always another. There's always another choice. You always have a choice to choose something different, choose something better. So my message to you today is to aim higher. As far as supplements, there's vitamin D. I know that because you're not going, say for instance, you're not going outside as much, or you want to minimize your sun exposure per se. You might now, as a result of that, may not have as much vitamin D in your system. So vitamin D is one of the main supplements I wanted to touch on. Outside of that, I definitely recommend talking to your doctor about that. Weight management, that's something that can ease your joints and ease your inflammation, and also allow you to exercise more, allow you to be more physical, and be more active. So weight management is a huge key component of managing your lupus. And also dental hygiene. I know that is a sleeper. Not a lot of people may have thought about that one, but dental hygiene is very important when it comes to managing lupus, because it's those flare-ups that can happen. Even if you're not taking care of your teeth, that can spread. Those inflammatory cytokines can spread to other parts of the body. And then lastly, emotional and mental health support. Please, 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 if you don't take anything else from this session, have a journal, whether it's a treatment journal or whether it's a personal journal. Being able to sit, be present, write your feelings out, write your thoughts out, write your ideas out is something that is very important. It helps with your overall health. And also, I would definitely recommend therapy, because it allows you to, talk your stressors out, so you can kind of triangulate what's going on. I know, especially in the day to day, you've got, especially for patients that do have lupus, they're battling a lot on top of everyday life, right? So being able to have a support system is something that I would highly recommend. All right. Let's see. Next, I want to talk about some very exciting developments. How are we doing on time? I think we're good. Okay. I want to talk about some new developments within the lupus and AI space. So there is a company called Deep SLE, and what they do is they utilize retinal images to identify systematic lupus, SLE, and related complications. You might be asking, how do they do that? So the average the average patient sees about 3 doctors over 6 years prior to diagnosis. But what these deep learning models can do, they can scan your electronic health records. They can identify the lupus pattern in years, not months. So when you're going to 3 different specialists, they might not be able to comb through all of your medical records at the same time, or they may take a little bit longer, to do so. But this company can see through the retinal images to identify different complications, and can diagnose utilizing the different score systems a little bit better. It analyzes your system timeline. When did these systems start? and what are some lab patterns that they're seeing. And one thing that also changed in the guidelines is, instead of saying, okay, well, we want to meet this certain threshold, and now this you're completely diagnosed with lupus, they're addressing it in a way it's called clinical relevance. So say, for instance, if you have brain fog, if you're having knee pain, and if you're also having a butterfly rash, all of those are clinically relevant. So they're kind of work your way and moving over towards the direction of, okay, this is clinical relevant compared, in terms of what the diagnosis could potentially be. It helps you differentiate the lupus flares from just a random infection. And also, once again, the goal is to cut the 6-year wait time down. And because lupus mimics 20 plus other conditions, it's oftentimes hard. Doctors have a lot on their minds, and so do you. So this AI has been revolutionary, and hopefully it definitely makes some impact moving forward. Next, I want to talk to you about lupus and AI in a program called FLAME. So that means Flare Machine Learning Prediction of SLE. So the good people over at the University of Florida did a retroactive study where they took over 28,000 lupus patients, and they analyzed from 2011 to 2022, came from diverse backgrounds. They used electronic health records and also the neighborhood social factors. So they used such as like health disparities. They looked at the neighborhood unemployment rates. They looked at the median income in your area. They looked at your access to health equity, and trying to figure out what societal stressors and environmental stressors can trigger flares. So what they found was that, number one, the AI was able to find flare prevalence equally across racial and ethnic groups. There was no bias detected. So that was good. What they also found was that the top 10% of the highest risk patients um, identified by the AI accounted for over 60% of all the flares. In the top 5%, and the top 5% of high risk patients, they had a 33% flare rate versus the 8% in the lowest risk group. So what this looked like is that 6 to 9 months, they realized that the headaches started to increase in frequency. There were little subtle changes in kidney markers. Then 3 to 6 months right before the flare, they had an organic brain systems that emerged. They saw protein in the urine trending upwards. They saw rash patterns changing. And then 1 to 3 months leading up to right before the flare, they saw multiple warning signs. And this is, when the AI will alert the doctor now. But this is something that the good people at University of Florida are working on, so that you can be able to tell when these symptoms are starting to build up, and then go seek accurate care, or to address the symptoms that they're starting to see. Right. And these are some of the clinical warning signs that they saw right before the flares. So headaches was one, organic brain syndrome, confusion issues. And they saw white blood cells in the urine, protein in the urine, rash changes, psychosis, fever, seizures, and then cerebral vascular events, so like stroke-like symptoms, and also blood in the urine. So over time, these are the clinical warning signs that they started to see that would produce a warning sign for flares. So the last slide I have is, what can I do today? So how can we make sure that we're on the same page? How can we make sure that we are growing to know ourselves? How can we make sure that we can support our own journey, not self-sabotage, but support our own journey as we either, battle lupus or support somebody who is fighting with lupus right now? So what can we do is you can track symptoms rigorously. You see headaches, rashes, fatigue, urine changes, write it down. You're late for work, write it down. If you're about to go to sleep and you don't feel like you're tired, write it down. Make sure that you're documenting everything. You can use apps like My Lupus, Manage My Pain, Folia Health, Lupus Minder, and Lupus Tracker Pro. Those are all easy ways to track your symptoms, track your signs. You can measure the different symptoms that you may have. The AI studies found the headaches were like the number one in early warning. So don't dismiss those, especially when it comes to brain fog and things of that nature. You want to preserve. I mean, the brain, how you have to be preserved, right? For sure. And then talk to your doctor about social stressors. I know sometimes we don't want to open up about those things, but if we have a job loss, housing instability, food insecurity, those they aren't just stress, like they're actual flare risk factors. Like you think about those. When I'm stressed out about something at work, I I feel it. Stress is something that we can't necessarily sometimes measure as far as on a scale of 1 to 10, but we can feel it in our body sometimes. So we need to be able to write those down. Don't skip routine labs, even when you feel good. It's better to be proactive about your body and about your condition. So once again, the trending kidney markers over time is how AI and smart doctors are able to catch the problems early. So even if you feel great, still go and get your lab test performed, and then ask the doctor, "Am I at a high risk for flares based on my history?" Like, make sure the doctor is up to speed on your history as well. Like, make sure he's looking through your profile, looking through your EHR. If you've had kidney involvement, if you've had a family history, if you've had frequent flares or any neuro symptoms, like you're at a high risk. So request more frequent monitoring and take the proactive steps to your care. So that is all I had today. Is there any questions? Please put it in the questions and answer chat
Yeah,
if
in
we have
the in the Q&A, please.
in the Q&A.
Yeah,
In the
thank you,
Q&A,
Dr.
please.
Thank you.
Absolutely.
That was very interesting presentation. I know you covered a lot, and I really appreciate it. I'm sure everyone on the webinars appreciate it as well. We do have some questions. So go ahead and feel free to put in the Q&A portion of the event if you have any questions while we're answering some that were submitted ahead of time. So I want to bring these to your attention, Doctor. Let's see. Sorry, let me pull them up real quick. Okay, the first question is hydrocortisone a medication for skin rash or butterfly rash?
Yes. Is hydrocortisone a medication for, you said, a topical rash?
Yeah, yeah, skin rash or the butterfly rash that's common in lupus.
Yes, yes, it actually is. So the thing is, hydrocortisone is one of the lowest dose steroid topical creams available. Um, Typically, you can put it on your skin. It can also be a part of the treatment plan. But I would recommend not putting it for an extended period of time, but it can help. The one thing also that it can do is also make your skin a little more sensitive to the sunlight as well. So when you're putting it on, it can relieve the redness, the itching and swelling. I would put it on at night because you're not going to be, hopefully when you're sleeping, you're not going to be exposed to the sunlight as much. But yes, it absolutely can be used for that.
Okay, good. The second one that was submitted is, can I take vitamin C and zinc while taking Benlysta?
Ooh, yes, you can. Yes, you can. So vitamin C and zinc are both great options to kind of boost your immune system a little bit. And both of those should be they should be relatively safe to take with Benlysta.
So do you recommend taking vitamin C and zinc on a regular basis?
Yes, I would. I would, especially because it boosts your immune system. And it also allows you, but in a healthy way. And we all need healthy doses of vitamin C and zinc. When at the first sign of a cold, that's the first thing I run to is some zinc to kind of make sure my levels there are elevated and to kind of knock the cold out that's coming. So that I would definitely recommend that. I mean, obviously check the doctor to see if there's any other things that you're taking, because sometimes specific drugs can bind to zinc and bind to other vitamins. But for the most part, zinc and vitamin C, I would recommend.
Okay. And then the other question that was submitted is low vitamin D a symptom of lupus?
Ooh, it can depend. It can depend, right? Because if we're avoiding sunlight, then we're not getting the natural vitamin D that we typically would. So that could be a sign that where we're not like I'm not saying it could be a sign as far as being diagnosed with lupus, but it could be a sign that we're not getting a lot of vitamin D, and it could be a sign that our skin is also sensitive to the sunlight as well.
Is it that you're already know that you're sensitive to the sun. You don't necessarily know you have lupus, but you have a sensitivity, so you're using much more sunscreen and not getting it as much. So
Correct.
people, by the time they're diagnosed, show low levels of vitamin D already because there's been stain out of the sun.
Exactly. But in terms of the lab test, that's not something that would be make or break. Like this is sign of lupus. At first, they would
That's not a marker. That's
yeah, it's not a mark. Yeah, correct. They usually start with an ANA test first, and then after that, they would once that level is above like a 160 or 320, that's like your foot in the door. And then after that, they have a whole myriad of different lab tests that they want to go through to double check to make sure you can differentiate lupus from other autoimmune diseases. So it's called the anti-nuclear antibody test. And like I touched on before, that's basically assessing whether or not your body is assuming that portions of your body, like the different cells and the nucleic properties like are in the cell that usually are swept up by the phagocytes or the macrophages rather, that they're not present in the body. So if if you have an if you have an antibody to to the nuclear the nuclear pieces of the cell that's supposed to be dead already in your body, but the macrophages didn't do their job, and those auto antibodies are present, then and present at a high level, that is a positive indication, right? And then you have to do a whole different slew of differential diagnosis tests to make sure that you do have lupus. But if it's positive, this definitely could potentially be a step in the right direction. However, once again, 10 to 15 healthy patients also can test positive for that as well. So you're not in the clear yet. It's not, a yes or no, like I have lupus, I don't, but it is okay, I have a little bit more clarity. And then they might do a confirmatory test. And then after that is when they start going into other tests to double check to make sure that or that you can get closer to getting the answers as far as being diagnosed with lupus or any other autoimmune disease.
okay. Karen in the chat, Karen has asked, said that thank you, that it was great information. Absolutely agree. So interesting. She wants to know, what is your interest in lupus? What's the connection? Although you did
Oh, what
say
is mine? Just lupus? Oh, wow. Thank you, Karen, for that question. So it was a specific day, my third year in pharmacy school, when I learned about lupus. And what struck me sitting in class, I still remember the day. The teacher said that 1 in every 250 African American women had lupus. And I was like, whoa. And it was disproportionately impacted by minorities. And I had no idea. And I was like, wow. I had no idea. And I went to a historically Black university, college university. So there's like 10, 12,000 Black men and women on campus. And, to think that 1 in every 250 has it and nobody said anything. And, people are battling these silent battles. And, growing up, I had family members from all over. So having that prevalence really struck out to me. And believe it or not, my fiance is actually on the board of the Northern California Lupus Foundation, and she did that on her own. And she's actually the reason why I'm here as well. So shout out to Allison Jones, Dr. Allison Jones. She's a pharmacist as well. And my connection there also is that there was a lady in my class that my fiance met out here in California on the lupus board for Northern California. Her sister was in my class. And so it was just like literally, mind you, we had moved all the way from North Carolina and Virginia. So that connection was just incredible. But as I mentioned before, I realized a lot of people were fighting silent battles. And that really made me want to support and be an advocate, because everybody needs somebody to look like to care. And that's something that really stuck out to me. And, the more that I leaned into it, the more I realized my god sister has it. She's battling. Like, it almost brought me to tears knowing that I had no idea she was going through this, and fighting it all her own. Right. Excuse me. Then come to find out my aunt had it as well. And, she's, once again, you realize that people are battling silent battles, are overcoming challenges that you had no idea. And then I realized, after graduating from pharmacy school, one of my good friends back home, that he was growing up, and it made sense later on, because sometimes we would see him and sometimes we wouldn't. Sometimes he would be able to come out and play and sometimes he wouldn't. And, you know, he would always be seeming as though he's going through some mental challenges or some mental battles. And I never really understood what it was. I just knew he really didn't understand it, and he couldn't even share it. And so it wasn't until later on that his mom reached out to me. We connected and she said, "Oh yeah, he has lupus." I was like, "Oh wow," because she saw some of the work that I was doing here. And so I connected back with him, and you know, we've been able to grow our relationship as well and reconnect there. But lupus is something I feel like it reminds me of the silent battles we all face as well. That's because sometimes we get in our own way. Sometimes we self-sabotage. Sometimes we don't recognize who we are inside, the gifts that we have inside that we're and our capacity and the capability that we have to share with the world. And so that's something where I feel like it almost mirrors, you know, a lot of us in real life. So my hope is that through webinars and through patient advocacy, we can spread the word out. We can also get more tests, and we can also get more treatments as well. And my hope is that a lot more pharma companies will, you know, seek to pursue this level and this space, right? Because we don't like there's still only 4 or 5 treatments really that are you know, having a huge impact in this role. And there's a lot of we don't understand. But the more people get into it, the more research, the more people are willing to share the word, the more we can expand this and hopefully find a cure one day. So thank you for that question. I appreciate it.
Yeah, we always say, you know, someone you know has lupus, even if today's the first day you've heard the term lupus, someone you know has lupus, because like you said, Dr. Hinton, it's a silent battle that people are facing. And I think it's helpful when people communicate, but sometimes it's very, very hard. There's a lot of discrimination out there. You know, people, most of the patients that confide, they talk about when they haven't been diagnosed yet. People are like, "What are you, lazy? Get out of bed, just power through. What's the matter with you?" You know, they don't understand it. And
Yeah.
so it's hard to talk about. But like you said, I mean, passionate advocates such as yourself, getting the word out and doing these presentations and talking to people, it opens it up. It gives people safe space, you know.
Yeah, yeah. Thank you, Elizabeth. And exactly, I completely agree. You know, it's like if you tell people what you have going on, they think you're using it as an excuse. And then if you don't tell them, then they feel like you're just, to your point, like they're lazy. You just, you know, you don't look sick. To Karen's point, you don't look
Right,
sick. I can't see it, and they don't understand the disease. And you know, we
right.
sometimes we don't feel like we should have to go all the way down the line and explain every single thing that's happened to us. Like, you should just treat people better. How about that? Like, you should, like,
Yeah,
you don't know how what people are going through. So and I think this is a great example of like why you should treat other people with grace, like why you should give, you know, be more kind to people, because you literally don't know. You can't see the amount of pain that people are facing just from the face value. So yeah, I
exactly.
completely agree.
And Karen adds here, thank you. And being a woman, it is often difficult to get doctors to believe these vague symptoms, especially when you don't look sick. Yeah. And I think there's a stigma, especially with women, and I think minority women even more so, that, you know, they get blown off by mostly male doctors and population of male doctors. Like, oh, they're so emotional, they just power through, you know. So yeah, you're right, Karen. It can be very frustrating. But the fact that the average time, I know it sounds long as 6 years as the average time for diagnosis. I mean, I remember when it took 20 years for my aunt to be diagnosed. She had started symptoms in the 60s and was finally diagnosed in the 80s. But so much damage had been done to her major organs. She didn't, you know, she only lived to 62 from there. So only almost not even 20 years after diagnosis. But for many years it was 15 years average diagnosis. Then it was down to 10. We thought that was incredible. Now it's down to 6. I see it as so much progress, you know,
Yeah.
that people are paying
Agree.
attention to this.
Agree. And I think it's forums like this and spaces like this and the great work that you're doing as well, Elizabeth, and the team as well, that is really going to carry this forward and allow us to knock this disease out once and for all. So
Yeah.
thank you all.
Well, thank you so much, Dr. Hinton, and we really appreciate the presentation. I learned a lot, and I'm around it a lot, but I just finding out about the new drugs and new treatments and your opinions about the combination of medications and vitamins, et cetera. It's very, very helpful. I wanted to let people know there was a question in the chat. Someone that joined late asked about recording. So I did want to remind, we will be sending out, we are recording this. We will be sending out an email with a link. So look out for an email this week, and it will have a link. You can refer back to it. Really appreciate the questions and active participation in today's presentation. So thank you, everyone. Great questions. Dr. Hinton's great presentation. Excellent. I hope everyone learned something, and be sure to rewatch it, share it with friends, share the link with anybody who wasn't able to make it as well, so we can be on demand. Thank you so much. If you have other questions, go ahead and email them. You can email questions to, let's see, I think we want them to communications@lfnc.org. That's communications@ Foundation Northern California.org. So lfnc.org. And we can answer any questions. We can get back with Dr. Hinton, and he'd be happy to share his answers or comments about those as well. Don't forget that we're now California Lupus Foundation. We've merged with Southern California and Northern California are now together. And if you want to check out our social media accounts, you can see any details on LFNC and LFSC's websites and their social media accounts. All right. Thank you so much. We hope that you enjoyed this presentation. We're going to try to get another one out before the end of the year. So look at the communications. Thank you again, Dr. Hinton. Thank you for everyone for joining, and I hope you have a wonderful weekend.
Thank you so much. All right, take care.
Thanks.